And it's important to understand that micronutrients serve as coenzymes and cofactors. Vitamins and minerals are, or let me say it the other way around. Coenzymes and cofactors are really just fancy words for vitamins and minerals. And coenzymes and cofactors help enzymes do their job. They help push the reaction through. So without adequate or optimal vitamins and minerals, enzymes are not going to be able to do their job, and clearly enzymes are involved. I mean, thousands and thousands of enzymatic reactions. There are certain limitations to our dietary reference intakes that we'll talk briefly about. Biochemical uniqueness, this is a huge one. You know, there is substantial genomic variation from person to person in your actual need for nutrients. Digestion issues, absorption issues, exposure to various endogenous toxins, exogenous toxins, and of course, drug-induced nutrient depletions, which we sometimes refer to as drug muggers, all are reasons why we need to be cognizant of our patient's micronutrient status. Bruce Ames, who was referred to as the father of genomic stability, wrote what I refer to as a sentinel paper back in 2002 in the American Journal of Clinical Nutrition, where he discusses how genetic uniquenesses affect vitamin requirements, sometimes up to 2 times or 10 times or even 100 times the reference intakes to protect against what he refers to as genomic instability. He writes, our analysis of metabolic disease that affects cofactor binding, so he's talking about vitamin binding, particularly as a result of polymorphic mutations. Polymorphic mutations referring to those genetic mutations that every one of us have, may present a novel rationale for high-dose vitamin therapy, perhaps hundreds of times the normal dietary reference intake in some cases. So what does that mean? So when you're running your patient's magnesium levels or folic acid levels or vitamin B12 levels using a lab, and it comes back with the results, and there's a number on that paper, and it's comparing it to this mythical normal reference range. Does that mean that that reference range is the normal range for every single person in the United States? Well, we're going to find out. So these are most of your vitamins, your water-soluble and fat-soluble vitamins. So your water-soluble vitamins include B1, which is thiamine, B2, which is riboflavin, B3, which is niacin, biotin. Sometimes pantothenic acid is referred to as B5. Pyridoxine is B6. B9 is sometimes used to describe folic acid, but you'll usually see folic acid referred to as folic acid or folate. And then B12 is cyanocobalamin. Vitamin C is also a water-soluble vitamin or ascorbic acid. So you see that there's a whole family of B vitamins, and that's why we call them the B complex. Your fat-soluble vitamins are going to include vitamin A, either in the form of carotenoids in foods, or retinol, retinoic acid in the body. Vitamin D, such as vitamin D2, which is ergocalciferol, or vitamin D3, which is cholecalciferol. Vitamin E, you've got your alpha, beta, gamma, delta, gamma forms. Vitamin K, such as the form of vitamin K1, K2. I believe there's also a K3. And then you've got choline, which is actually sort of a fat and water-soluble vitamin. Does anybody remember where we talked about choline in the macronutrient lecture? We talked about it in the context of phospholipids. It was part of that hydrophilic structure of the phospholipid. And these are your minerals. They can be divided into your major minerals, and we call them major minerals not because they're more important than trace minerals, but because they're found in your body in greater than 5 grams. And the others are your trace minerals and your ultra trace minerals as well. So we see that there's only a few dozen vitamins and minerals that we know about in human physiology. Only 13 of them have dietary reference intakes, but these few dozen are responsible for literally thousands of reactions in your body. Thousands. So to have a deficiency or an inadequacy of one has multiple implications, you can imagine. So are we going to get all of our micronutrients just from our diet? Well, In this particular article published in 2006, the authors write, 70 diets were computer analyzed from the menu of athletes or sedentary subjects seeking to improve the quality of micronutrient intake from food choices. Surprisingly, all of these dietary analyses fell short of the recommended 100% RDA micronutrient level from food alone. Therefore, based on diets analyzed for adequacy or inadequacy of macro and micronutrients, a challenging question is proposed. Does food selection alone provide 100% of the former RDA or newer RDI micronutrient recommended daily requirement? Well, I guess the answer depends on what you're eating. Depends on the type of diet you're eating, right? What do you think the answer is going to be if you're consuming the standard American diet? This data is actually starting to get a little old. This was from the NHANES, or the National Health and Nutrition Examination Survey, where the top 7 nutrients in Americans were analyzed and found to be most deficient in, at the very top of that list, potassium. Up to 97% of Americans not getting enough potassium. Fiber, we're not surprised by that. A very recent study that I just showed you in the macronutrient lecture showed that Americans are still not getting the fiber that they need, or when they analyze the data from the past decade. Folic acid, vitamin D, magnesium. So what does all of this mean? Why, if we know that micronutrients are so important, why aren't more healthcare professionals incorporating nutrition into their treatment plans? Well, I think that has to do with the fact that disease really does exist on a continuum. We initially have these biochemical alterations, such as maybe fatigue or maybe a little achiness. So no overt symptoms, right? I mean, everybody's a little fatigued, a little achy occasionally, but we don't really think of that as, occasional fatigue or achiness as being like a big deal, at least not right away. And eventually it moves into impaired cellular function, where now we're going beyond fatigue. We have pain, we have migraines, you feel cold, you're gaining weight. Your fasting blood sugars are really starting to push it. You come in with let's say you're testing in a 98 or a 99, right? We know that once you start going beyond 100, that's impaired diabetes, or impaired glucose tolerance, or borderline diabetes. So we see subclinical manifestations. There's still really no ICD-9 code for this yet, right? So you might say something to your healthcare practitioner, and he or she might say, well, we'll keep an eye on it. Eventually, it progresses into morphological or functional changes, and now we're starting to see elevated TSH, high homocysteine, low vitamin D. If you're running functional diagnostic labs, you might see elevated methylmalonic acid, elevated form-aminoglutamate, which are functional biomarkers of B12 and folic acid, respectively. So now your patient's in early stage disease, and still there's really not a whole lot that's being done for them, right? I mean, maybe occasionally. But it's not until the patient has diagnosed pathology, a diagnosis of hypothyroid, a diagnosis of inflammatory bowel disease or cardiovascular disease or type 2 diabetes or whatever it is, where there is now tissue damage, there is organ failure, before something is done about it. There's an ICD-9 code, and it is billable. And that, just keeping it real. Most chronic diseases, which are demonstrably improved over time with appropriate nutritional intervention, begin with metabolic and biochemical changes. This is why incorporating some functional diagnostic labs can be really beneficial, which will probably be discussed a little later, to help identify these earlier stages of change. So now that we have an appreciation for the big picture and we've sort of set the stage, let me review some of the roles of these multitasking micronutrients with you. Just an overview again. So we know that micronutrients serve as building blocks. For example, amino acids. We talked about amino acids becoming protein, but the sulfur component of that amino acid, such as taurine, such as cysteine, in this case cysteine forming disulfide bridges for proteins. I'll show you a picture of that, an example being insulin. I showed you the picture of that liver detoxification slide where we saw the sulfation pathway in phase 2. Minerals such as calcium and vitamin K2 or vitamin K2, magnesium, or boron being very much related to bone health and needed for bone health. We know that micronutrients are components of enzymes. We already talked about the fact that micronutrients serve as the cofactors and the coenzymes for those enzymatic reactions. Cell signaling, they absolutely serve as cell signaling molecules such as vitamin D, which we'll talk quite a bit about, that help maintain blood levels of calcium and phosphorus, and so much more. Micronutrients that are involved in direct chemical activity, such as vitamin E, that help to quench hydroxyl free radicals. Micronutrients that are involved in hormone regulation, such as selenium and iodine being involved in thyroid health. Of course, we don't want to overdo the iodine, especially if our patient's got a diagnosis of Hashimoto's autoimmune. Micronutrients involved in methylation, such as B2, B6, B12, folic acid, choline, trimethylglycine, magnesium, all of these incredible micronutrients involved in all of these different tasks. And one area that I think is very important, not that the others are not important, but being involved in maintaining cell membrane integrity and in the prevention of oxidative damage, or the prevention of, or the treatment even of genomic instability, or even reversing DNA damage, which can be measured, by the way. This is that picture that I was telling you about, just an example of human insulin, which is, you can see there are essentially 51 amino acids in these two short polypeptide chains, and those are simply the sulfur molecules that serve as the disulfide bridges that are part of the side chain of cysteine. Here's a paper that was published in 2001. Michael Fennick and his colleague Lynette Ferguson put out a paper on vitamins and minerals and genomic stability in humans. And they write, there is increasing evidence that higher levels of many such micronutrients may be necessary for various DNA maintenance reactions, and that the current RDAs for some micronutrients may be inadequate to protect against genomic instability. Okay, so what is this about? Guys, this is about the entire industry, the entire anti-aging industry. There's a whole industry out there that's talking about anti-aging and finding ways to slow down the clock. And this is completely related to that. So when we talk about genomic stability or genomic instability, what we're talking about is anti-aging, we're talking about the prevention of DNA damage, and we're talking about the critical importance of micronutrients in that process. And in this paper written by Fennick back in 2002, he writes, diet as a key factor in determining genomic stability is more important than previously imagined because we now know that it impacts on all relevant pathways, namely exposure to dietary carcinogens, activation and detoxification of carcinogens, DNA repair, DNA synthesis, and apoptosis, which we know is cell death. And in this article by Bruce Ames, we talked about Bruce Ames as being the father of genomic stability. He writes, a deficiency of any of the micronutrients, folic acid, B12, B6, niacin, vitamin C, vitamin E, iron, zinc, mimics radiation in damaging DNA by causing single and double strand breaks, oxidative lesions, or both. And you know why I know this for sure? Because when we run labs in our clinic, we actually see in patients who have never had radiation or chemotherapy spill biomarkers such as 8-hydroxy-2-deoxyguanosine, which is a critical biomarker involved in that's basically a biomarker of DNA damage. And we see people test positive for this all the time. So he says remedying micronutrient deficiencies should lead to a major improvement in health and an increase in longevity at low cost. In other words, what I was saying before is that, just to clarify, 8-hydroxy-2-deoxyguanosine is a biomarker that's seen a lot when people go through radiation or chemotherapy. That's caused DNA damage, right? But what I'm saying is that I have seen many people, including children, test positive for the 8-hydroxy-2-deoxyguanosine biomarker, and they've never had any of that kind of radiation or chemotherapy. So the question is, could it be related, at least in part, to this deficiency of micronutrient in their standard American diet? In a very recent paper, like recent as in like 5 days ago recent, in the Journal of the Academy of Nutrition and Dietetics, the authors write, in the setting of heart failure, many potential benefits of micronutrient supplementation have been proposed, including again this reduction of oxidative stress, which again is related to genomic stability, and inflammation, and the modulation of the renin-angiotensin-aldosterone endocrine system. So we only have time to talk about, barely have enough time to talk about a couple of these micronutrients. I wish we had more. Just a few key pearls about folic acid to share with you. Again, we know that folic acid is one of our B vitamins, one of the B complex. Involved in hundreds of functions, but particularly in energy metabolism. I'll show you a picture. Detox, we've seen that picture. Brain health, heart health, vascular health. Endothelial health. Remember the eNOS enzyme that facilitated arginine in becoming nitric oxide? I showed you that one. And of course we all know about folic acid being extremely important for proper cell division, right? What do we do when our patient is pregnant? We put her on a prenatal. We double her folic acid intake to at least 800 micrograms daily to help prevent certain neural tube defects like spina bifida and anencephaly. Okay, so this looks like a complicated picture, but it's really not. It's just basically showing you the different energy-producing pathways, glycolysis, Krebs cycle, electron transport chain. Here's the point. Everywhere you see a little purple box is a place where there's a vitamin involved or a mineral. And there's a lot of purple boxes on that screen. So there are many different places where your vitamins and minerals are involved in the production of energy. So it is true that vitamins and minerals don't give you energy in the sense that they're not, you know, energy, if we define energy as being synonymous with calories, but our vitamins and our minerals are very much involved in the production of energy because they're involved in all of the energy producing pathways. This is another slide that's kind of saying the same exact thing, except you're seeing a variety of other nutrients, including lipoic acid and CoQ10 at the very end there of electron transport chain, all of these really, really critical nutrients. So in your patients who are complaining of fatigue and various other fatigue-related disorders, you definitely need to assess their micronutrient status. This is one particular lab that looks at markers of methylation, namely B12 and folic acid, methylmalonic acid, or MMA, as being a functional biomarker of B12 and form immunoglutamate. Sometimes we call that FIGLU as being a marker of folic acid, and if this particular functional marker is being spilled into the urine in high levels, then we can assume that it's because there's not enough of the nutrient to help facilitate that reaction. That's a whole other conversation, so if you're not quite making that connection, I would ask you to just hang on to the lecture on assessment and functional diagnostic assessment. And again, here's that same slide over and over again to help kind of really drill this point where we see methylation and the need for folic acid in not just phase 2 but phase 1. So you'll see it in phase 1 and in phase 2. And for those of you who are not quite familiar with this process, I apologize. I think that either it's been discussed or it will be discussed in a detox lecture by Dr. Evans. Just a very simplified depiction of the folic acid cycle. Folic acid goes through a few steps to ultimately to become 5,10-methylene tetrahydrofolate. And then there's a really important step here that's involved in the making of your active folic acid, or your 5-methyl tetrahydrofolate. And that step requires an enzyme called MTHFR, or methyl tetrahydrofolate reductase. So the point here is just to let you know, if you're not already aware, that a significant percent of the population has a defect with this particular enzyme, or a SNP, or a single nucleotide polymorphism, or a genetic variation, or whatever word you want to use. But the bottom line is, we're poor converters. There are a significant percent of people who are not converting well. Now, if you're heterozygous for that SNP, which is extremely common, you may have some conversion issues. But if you're homozygous for that SNP, the conversion issue will be significant. And you're going to really have to assess that patient's folic acid. You can do that by looking at what biomarker. You can look at that by looking at their homocysteine levels, because we know that homocysteine is needed for that active form of folic acid is need for homocysteine to recycle through the different methylation reactions. So a good tip-off is if your patient's homocysteine levels are high, it's a good indicator that they'll need some extra folic acid. Some of the diseases and conditions related to poor folate metabolism, we've already discussed spina bifida and other neural tube defects, but depression, anxiety, OCD, Alzheimer's, cognitive decline, heart disease, stroke, cancer, high blood pressure, poor detox, we've seen that slide, poor energy, we've seen that slide, anemia. Anemia can be related to poor folate metabolism or not enough folate, especially your macrocytic and your megaloblastic anemias. And as we become further advanced in our understanding of the role of B vitamins, we see that it's involved in even more than what we originally thought, such as macular degeneration in women. In this particular article that was published in February 2009 in the Archives of Internal Medicine from researchers from Harvard, we see that these guys say these randomized trial data from a large cohort of women at a high risk of cardiovascular disease indicate that daily supplementation with folic acid, pyridoxine, and cyanocobalamin, that was B12, may reduce the risk of advanced macular degeneration. Some of the drugs that can induce nutrient depletion are here on this list. Let me just mention that a lot of us receive training on drug-drug interactions. A lot of us get some training on drug-nutrient interactions. But how many of us are taught about the nutrients that are depleted because of a drug? Right? We're not really taught that information. We're really not, there's never really a discussion about what kind of nutrients we need to, your patient's at higher risk for because of the drug. It's always the other way around. Don't eat this nutrient because this patient is on this drug. So I think it's fair that we also be aware of drug-induced nutrient depletions. All of these drugs are involved in depleting folic acid. Interestingly enough, oral contraceptives, right? So isn't that ironic for a woman to be on the pill? Decreasing her needs for, or decreasing her body's levels of folic acid, the very nutrient that she's going to need if she wants to get pregnant down the road. Some of your sources of folate, foliage, right? That makes sense. So your green leafy veggies, legumes, seeds, fortified grains. Some recommended doses. 400 to 800 micrograms of active folate is what I would recommend, which is also known as 5-methyltetrahydrofolate. If you don't have access to active folate, you can use a little extra regular folic acid. So the question always comes up as to whether high doses or higher doses of folic acid is really a good thing, or is that safe? Meaning, is it okay to start pushing over 5,000 micrograms? You know, that's quite a bit. Well, we know that folic acid is a methylating nutrient that's involved in gene silencing, right? It's going to silence the promoter region of the gene that's involved in the expression of that gene. If you're consuming a whole foods diet, you're probably going to get much more than just folic acid. You're going to be consuming B12 and B2 and choline and a variety of other methylating nutrients as well. So I think the answer to this is going to depend on the patient's unique genetic polymorphism. If the patient's homozygous for the MTHFR SNP, then yeah, they're going to need some higher levels. I don't know about going over 5,000, but they're going to need higher levels than a person who doesn't have that SNP. I think it's important that we understand the background, that timing is everything, and we understand the background of the patient's situation. For example, if there's an existing carcinoma, gene silencing may not always be a good thing. We're moving on to vitamin D, the sunshine vitamin. We know that vitamin D is obviously involved in bone health, but one of the things that we're learning is that it's also involved in the regulation of your immune system. I think there are some interesting papers out there that talk about its role in the prevention of certain kinds of cancers. We'll talk about that specifically in a little bit. Vitamin D has shown to help decrease inflammation via a particular substance called NF-kappa B, which you can really think of NF-kappa B as being a major intracellular amplifier, which is going to increase the production of certain mediators, like your cytokines and your prostaglandins and your leukotrienes. So vitamin D has been shown to decrease inflammation via this NF-kappa B, by decreasing NF-kappa B that's associated with certain types of inflammatory bowel diseases like your Crohn's and your colitis. So that's not a picture of bacon. I know it looks like a picture of bacon frying in a cast iron skillet, but actually it's a close-up of 3 longitudinal sections throughout the colon wall of an individual with ulcerative colitis. course, rickets is still present in the U.S. All right, so very quickly, the sun activates the 7-dehydrocholesterol in the skin, then goes on to get hydroxylated once in the liver, and then hydroxylated a second time in the kidney, and then we have 1,25-dihydroxyvitamin D, the active form of vitamin D. Michael Hollick, who's really an international, truly a world expert on vitamin D, an MD, PhD, writes in an article that was published in the American Journal of Clinical Nutrition in 2004. The purpose of this review is to put into perspective the many health benefits of D and the role of vitamin D deficiency in increasing the risk of many common and serious diseases, including some common cancers, type 1 diabetes, cardiovascular disease, and osteoporosis. I thought this was interesting that vitamin D deficiency is often misdiagnosed as fibromyalgia. So we definitely want to check our vitamin D levels on all your patients with fibromyalgia or anyone who you diagnose with fibromyalgia. That studies in both human and animal models add strength to the hypothesis that the unrecognized epidemic of D deficiency worldwide is a contributing factor of many chronic debilitating diseases. In this particular article, published in 2008 on D and MS, the authors write that due to its immunosuppressive actions, it has been suggested that 125 vitamin D may prevent the induction of MS. And in this particular article, published in 2009 in the Archives of Internal Medicine, this was an article that looked or analyzed data from the NHANES 3 study or survey, which is considered to be the largest and most nationally representative study of the link between vitamin D and respiratory diseases and respiratory infections. So this particular research team analyzed the blood levels of vitamin D, and they looked at the levels from 19,000 adults and adolescents, which they felt was representative of the U.S. population. And what they basically found out, or what they discovered, was that study participants with the lowest blood D levels, less than 10 nanograms per ml, were about 40% more likely to report having a recent respiratory infection than those with vitamin D levels that were over 30 nanograms per ml. They wrote, in the largest and most nationally representative study of possible links between vitamin D and respiratory infections, people with the lowest blood vitamin D levels reported having significantly more recent colds or cases of the flu. Moving on to vitamin D as it relates to dysinsulinemia and diabetes, there's a lot of data on this subject, and I'm highlighting just a couple of studies about how low vitamin D increases insulin resistance, how low vitamin D prevents proper insulin release from the pancreas, and also its immune modulating and anti-inflammatory benefits for the prevention of type 1 diabetes. So here's a really interesting study, and actually this study looked at a lot of different things, but one thing I thought was really interesting about this particular article was that and this is a relatively recent article, where they write, our results suggest that hypovitaminosis D, so low D, is a risk factor for developing insulin resistance independent of adiposity. Right, so what they're saying is that the relationship was independent of adiposity. So, you know, obviously most overweight or obese individuals will have insulin dysregulation, but not everybody who's insulin resistant is overweight. So what they're suggesting is that the relationship was independent of obesity or adiposity. So we need to remember that our micronutrients are involved in we need to remember that insulin resistance is not just about adiposity, and that low vitamin D can be a risk factor for insulin resistance, even independent of that. And this is an interesting slide that shows insulin's, sort of an illustration showing you insulin's ability to bind with the receptor, and the strength of that signal is going to be dependent upon the presence of adequate nutrients, like your vanadium and your chromium and lipoic acid, magnesium, and vitamin E. So the capacity of the insulin receptors are compromised because of nutrient insufficiencies. The internal message to the cells becomes reduced, and the efficiency of that cell is compromised. So the integrity of the health of the receptor is what we're talking about. Right? So we're not just concerned about carb counting for our patients with diabetes. We're also interested in understanding their micronutrient status, because we're interested in the health of their receptors, so that when insulin does bind with those receptors, that there's a healthy communication that's taking place. In this particular article, in the American Journal of Clinical Nutrition, just recently in 2011, The authors write, in adults at risk of type 2 diabetes, short-term supplementation with cholecalciferol, that's your D3, improved beta cell function. And in this article, they write, based on available clinical and epidemiologic data, the positive effects of vitamin D seem to be primarily related to its action on insulin secretion and sensitivity, and secondary to its action on inflammation. Recent article in 2012. This is a slide that's mostly about healthy blood levels of vitamin D, just to kind of give you an idea. So if your patient's got less than 20 nanograms per ml, we're considering that deficient. Between 20 and 32, we're considering that insufficient. Between 33 and 80, we're considering that sufficient, with optimal being between 50 and 80 nanograms per ml. And once your patient starts pushing 100, I personally think that's going a little too high. Vitamin D has a short half-life. We want to get it checked as often as we can. Insurance may only allow it to be checked once a year. Now, you have to also be aware of the units that your lab is using. If they're using nanograms per ml, that's one thing, but you have to make sure that if your lab is using nanomoles per liter, that you're converting, because that's going to be different. You're going to have to multiply by 2.5 to convert. This is one of my favorite studies. I think that this is profound and should have gotten the cover of Time magazine. In 2007, Garland and his colleagues showed that women with vitamin D levels less than 52 nanograms per ml had an increased risk of breast cancer by 50%. He writes, an intake of 2,000 IUs per day of vitamin D3 and, when possible, very moderate exposure to sunlight could raise serum 25-hydroxy-D to 52 nanograms per ml, a level associated, and of course these are just association studies, with reduction by 50%. Guys, that's pretty big. That's a huge number, right? 50% reduction by 50% in incidence of breast cancer. I mean, can you find a drug that could do that? I don't know that there's even a drug that can do that, according to observational studies. So, for your reference, amount of vitamin D in food, baked herring, 3 ounces will give you about 1,775 IUs. That's quite a bit. 15 to 20 minutes of sun exposure, where your face and your arms are exposed, will give you anywhere up to 2,000 to 5,000 IUs of vitamin D, depending on the intensity of the rays and where you live, how far you are from the equator. Oh gosh, I just got the 10-minute mark. Okay. And supplement dosages, 400 IUs is the current recommendation, but I think that we now understand that 1,000 IUs is what your patient's going to need just for maintenance, right? So just when you get your patient up to a healthy dose, or excuse me, a healthy blood level, 1,000 IUs might help to maintain that. I can tell you personally that I cannot maintain a healthy blood vitamin D level unless I'm taking 7,000 a day. So this variation, right, there's really no one way, one number for everybody. That's going to just depend on each individual. And I think the only way to really know is by doing what? By testing. By testing them and then retesting them and finding out what works for them. Because we also have what's called vitamin D receptor polymorphisms. Some people may have genetic variations that make their body need more vitamin D versus others that need less. 2,000 if you're insufficient, 5 to 10,000 if you're deficient. Once you start pushing 100,000 IUs, then we're talking about D3. We're not talking about prescription D2 or ergocalciferol. D3. I want to make sure you're clear about that. Vitamin D is very inexpensive. We're moving on to magnesium. Magnesium, a mineral involved in hundreds of reactions in the body, involved in 2/3 at least of the enzymes involved in detox. Remember we said that the delta-6 desaturase was a zinc and magnesium dependent enzyme? And remember we said that magnesium and taurine sort of run together. They need each other to work. So if your patient's protein malnourished, you may not use magnesium well. Magnesium is going to play a very important role in all of these things, supporting proper energy production, bone mineralization, right? Calcium is not the only player in bone health, right? Neurotransmitter metabolism, intestinal motility, normal heart rhythm, blood clotting, muscle relaxation, nerve transmission, helping prevent nocturnal leg muscle cramps, estrogen detoxification, which I'll show you my crazy slide, I call it, vascular health. This is my crazy slide. And there's magnesium. This is a slide, I think Joel will show you this, maybe, possibly. Nutritional influences on estrogen metabolism. And magnesium is a big part of that. Poor magnesium status can increase your risk for cardiovascular disease, renal disease, diabetes, toxemia of pregnancy, hypertension, post-surgical complications. Here are some of the forms of magnesium. Magnesium oxide is the one that you're going to see the most in your cheaper over-the-counter supplements. You'll see magnesium oxide. In your higher quality products, you'll see magnesium gluconate, magnesium glycinate, magnesium citrate, malate, aspartate. Oral magnesium chloride, that's going to be found in milk of magnesia products. Magnesium stearate is the form of magnesium that you see as binders and fillers and vitamins. Some of your food sources will be your dark green leafies, collards, dandelion greens, kale, also whole grains, avocado, the cacao bean, legume like buckwheat. Magnesium is lost in cooking some foods, even under the best conditions. We have to be really careful. Magnesium is very delicate, so to retain it, you want to cook foods in a minimal amount of water and for the shortest possible time. If you're going to supplement, you can start with about 100 milligrams. You can take it as high as 400 milligrams, just depending on that individual's needs. This is a list of some of the food sources of magnesium. You'll see that it's especially high in nuts, legumes, oats, and barley. You can check this slide out. And here are some of your references. Some of the drug-induced nutrient depletions of magnesium, once again we see oral contraceptives at the top of that list, but also hormone replacement therapy, digoxin, loop diuretics, potassium-sparing diuretics, a very common drug, HCTZ, right? Many people on that one, corticosteroids, certain antivirals, certain antifungals, certain antibiotics. We have just a couple minutes left, and I'd like to just take a few minutes to go over this case study with you and then wrap it up. So if we had a 48-year-old perimenopausal female, family history of breast cancer, she comes in and she says that she's complaining of fatigue, multiple chemical sensitivities, so specifically she says she can't drink coffee or walk into a new building, she gets migraines and occasional heartburn, and complains of irritable bowel syndrome, not to be confused with inflammatory bowel disease. She is 5'6", weighing in at 160 pounds, BMI of 25, BP 128 over 85, so slightly hypertensive. Her current diet, you assessed it to be a standard American diet. She takes cimetidine and ibuprofen as needed. She reports taking 1,200 milligrams of calcium carbonate, and she says that she walks her dog most mornings but doesn't really break a sweat. And in terms of lifestyle, she says that she complains that she's stressed from work and stressed because of her children's expensive college tuition. So right away we can say that this woman is probably what? In an acid-loaded state from what? Her standard American diet? And is that a good thing for a cancer patient? Definitely not. Some of the significant lab findings were that her blood sugar, her fasting blood sugar was 108. So we know, is that a normal blood sugar? No, but is that type 2 diabetes? No, it's impaired. So borderline. Her alk phos level, which is a marker of mineral status, was low, 22. Her total protein was 8.1. We'll talk about what that means. Her TSH was 4.3. Now, I know that 4.3 for some labs comes in within the normal reference range, but is that really an ideal TSH? No, definitely not. That is definitely subclinical what? Hypothyroid. Her red blood cell distribution width, which is another marker of methylation, was high, 15%. Hematocrit 35, hemoglobin 11.5, and her 25 hydroxy D was 22, so that's low. So what nutrients might be involved here? Well, the fatigue and anemia, right away we're going to think about our Bs, magnesium. We didn't get a chance to talk about CoQ10, but CoQ10 is another extremely important, probably the second most important antioxidant involved in the production of energy. Mild hypertension, we might think about magnesium glycinate. Insulin sensitization. Remember I mentioned the essential fatty acids being a what? A PPAR agonist. We said that PPAR agonists are, there are drugs out there like metformin which help to sensitize insulin, and we said essential fatty acids can do something similar. Chromium, maybe vanadium. Her alk phos levels were low, so she may have low mineral status, particularly as it relates to zinc or B6. Now, that 8.1 high protein really is not because she's just got such great protein status. It's probably more an issue related to poor amino acid recycling and absorption issues. A really healthy total protein level is going to be between 7.0 and 7.4. When your patient starts pushing 7.4, they may be within the range, but that's not necessarily an indication of good protein status. Subclinical hypothyroid, so we might consider some selenium and iodine and protein, assuming there's no Hashimoto's thyroiditis. Her high RDW, meaning suggestive of needing more methylating nutrients like folic acid. Consider magnesium for migraines. I know we didn't talk about every single aspect of these. The B12 and folic acid being helpful for the anemia, but if depending on what her total iron binding capacity and percent saturation is, she may need some iron. Think about the low vitamin D. Think about that Garland study. Remember we said that levels at 52 nanograms or anything lower than 52 was at what percent increased risk for breast cancer? 50%. And then she's on that drug cimetidine that goes by the name Tagamet, or being what's called a cytochrome P450 inhibitor. So that means that it slows down the rate in which other drugs get detoxified, right? This is a drug-drug interaction. So if she's having decreased clearance of other drugs, that may be one of the reasons why she's feeling that sort of toxic, along with all this other stuff. So you say that this is all fine and well, and you just don't have enough time to assess your patient's status. I invite you to refer it out. Right? There are plenty of dietitians who would be happy to do that for you. All right, so you can seek out a dietitian or a certified clinical nutritionist. My son showed me this. He was so tickled when he found this, and he gave me this slide. And you may have seen this before. Hopefully, this is the new pharmacy of the future. So, some of our key take-home messages. I invite all of you to be ambassadors for Food First. Hopefully we have now learned that micronutrients need to be consumed in not just adequate, but really optimal levels for optimal health. I would also encourage you to be willing to ask questions. And if you can't, because you don't have the time, to have someone ask those questions for you. Ask questions such as, what is the patient eating? Right? You got to know what they're eating. What potential drug-induced nutrient depletions might exist? What is the patient's unique nutrigenetic needs? You know, Dr. Jeff Bland, who is an internationally renowned expert in the field of nutritional medicine, says something like, the questions that we ask determine the answers that we come up with. And I just think that's a really brilliant way of looking at it. Keep in mind that there are dozens of multitasking nutrients that we just discussed that are responsible for thousands of reactions. These nutrient deficiencies don't stand alone. It's really important that we look for patterns. So, whenever possible, use your traditional and functional diagnostic labs to determine your patient's vitamin and mineral status. Also, challenge yourself to think of drugs as an absolute last alternative if you can. It's really hard to do that, I know. This is definitely something that takes practice. One way to help try to organize the clinical framework for all of this information is to ultimately boil it down to two questions, and that is trying to assess what are those things that need to come out of your patient's diet/life that are offending their system, up-ramping their inflammation, and what are those things or those nutrients that need to go into their diet to help with optimal nutrition and function. And finally, consider that nearly all chronic disease can be addressed with food and nutrition. You know, knowing that our food carries the information needed for this genetic modulation that we've been discussing, what we eat really does become who we are. If you want to build your Taj Mahal, if you want to build that Taj Mahal and it's operating on a structure of sand, it's going to collapse sooner or later. So as I said when we first started, food is not just medicine, food is really powerful medicine. And again, to create that Taj Mahal, you're going to have to be willing to start with a foundation that begins with food first. So now that you know, my question for you is, what will you do differently? So I thank you for your attention this morning.
Thank you, Sheila. There'll be time at the end of the day for questions for Sheila and the other presenters. We have a break now. We'll be back here at 11 o'clock with Dr. Jerry Mullen.